Coming up today on the UW Medicine Pulse podcast, we visit what is perhaps the most important institution in the Pacific Northwest.
You absolutely want to have a resource like Harborview in your community because if you are injured, you need to go to a place where they have a lot of experience in dealing with injuries and have those resources immediately available.
We'll learn of new guidelines for performing CPR and how they're saving lives.
The big change, I think, in CPR has been a refocus on the importance of high-quality, minimally interrupted CPR.
And we'll help you understand the difference between emergency care and urgent care.
When you and I were growing up, there was no such thing as urgent care. There was either your physician's office or the emergency department.
This is the UW Medicine Pulse with Marty Reamer. Real-world stories of the discoveries being made at UW Medicine and the impact they're having on people here in the Pacific Northwest and around the world.
Trauma care, emergency care, urgent care. The terms sound the same and are even used interchangeably at times, but there are noteworthy distinctions. And at UW Medicine, there are remarkable facilities that specialize in each type of care. Beginning with trauma, be it a fire, a serious crash, a shooting, or a chemical spill. When it comes to serious injury, the Harborview Medical Center trauma team gets called into service.
Teresa Ewan's been following this and is live at Harborview, where two of the victims are this morning.
Man and woman to safety. They were taken to Harborview for treatment.
One of them sustained possible life-threatening injuries, stab wounds. He was taken to Harborview.
Like a guardian keeping watch, Harborview Medical Center sits perched above downtown Seattle and is without question one of the most vital institutions in all of the Pacific Northwest. Eileen Bulger is a UW Medicine physician and chief of trauma at Harborview Medical Center.
Harborview is actually the only level 1 trauma center for both adults and pediatrics for not only the state of Washington, but we also serve southeast Alaska, western Montana, and parts of Idaho. So it's a huge catchment area for critically injured patients. So not only locally, but throughout the Pacific Northwest.
When you walk the halls of Harborview or talk to the staff there, you immediately get a sense of the facility's long history and its importance to Seattle and the surrounding communities. Whether it's the Art Deco architecture of the original center wing, which dates back to the hospital's grounding on this site in 1931, when it was dubbed the finest facility to care for the sick anywhere in the United States, to the conference rooms in one of the newer adjacent buildings that today double as command centers in case of a disaster. It's the people in these rooms that will coordinate the relief effort when the unthinkable happens.
Yeah, the ambulance crew just arrived.
Harborview is this region's primary treatment facility for emergency services, trauma, burn, and communicable disease.
Well, you absolutely want to have a resource like Harborview in your community because if you are injured, you need to go to a place where they have a lot of experience in dealing with injuries and have those resources immediately available. What will often cause death in the first 2 hours is rapid bleeding, and you really need to be able to get to a place that can control that bleeding and can manage you effectively.
Well, I see that we've got 2 ambulances there. We've got 2 ambulances, stretchers.
It's a Thursday afternoon in the Harborview Emergency Department. It's midsummer. It's a sunny day, which means it's likely to be busy.
We know traditionally at Harborview we do refer to the trauma season, which is the summer.
Ann Newcomb is a UW Medicine registered nurse and clinical director of Harborview's emergency department. She, along with the medical director there, manage the operations in the city's busiest trauma center and emergency room.
So here are the boards. These are our FirstNet tracking boards, and we can track our patients on these. From here I can see that we've had people with, unfortunately we have somebody who has lost a finger, we've got somebody with abdominal pain, somebody who's been assaulted, we've had we use the term versus quite often, meaning car versus ped, car versus pedestrian, and I see on the board that we have scooter versus light post. So that would mean to me that there was a person riding a scooter that unfortunately hit a light post.
What strikes me, in addition to the volume of cases Harborview treats, is the range of scenarios they have to be prepared for. One moment it's a scooter colliding with a lamppost.
We've got somebody who's had a chemical exposure.
The next, a gunshot victim is en route.
What happens when we know a major trauma patient is coming in, the system gears up immediately. We call what's called a full trauma team activation, which brings to the emergency department all of the resources, all of the surgical team. It brings blood products, brings laboratory technicians, all those people to the emergency department to augment the care of that patient. And it puts the operating room on standby to have a room immediately available. So literally, if it's something obvious like a gunshot wound, I can have the patient in the operating room within 5 minutes. And it's just a tremendous commitment on the part of the staff that allows that to happen.
Strike the box for 671 Boylston Street. We have multiple people down.
And then, unfortunately, there are the events that no one wants to imagine, but Harborview has to prepare for. A bomb goes off at a public gathering, like at the Boston Marathon. Or, as has long been predicted, a major earthquake pounds the region.
Harborview is what's called the Disaster Medical Control Center for the region. So that means that we're responsible for coordinating the distribution of patients throughout the region when there's a multiple casualty event. So generally speaking, the first 20 patients or so come here anyway. But then if there are more patients than that, we would be in charge of distributing them among the area hospitals. And we routinely drill that and practice that with disaster drills for a variety of different scenarios, both adult and pediatric. You heard them? We actually try to create a scenario that's as realistic as we can. And we'll often bring fake patients into the emergency department.
I just want to give a hair down.
And have to triage them and work with the EMS system to define the scope of the event and be on the radio and communicating with the other hospitals about how we would be sending the patients around.
What's happened today is at 8:30 today, we're going to get a call from a local hair salon. There's been an acetone spill, causes an explosion. There'll be burn victims taken here to the hospital.
So actually what we have is, and what's recommended is you have sort of an all hazards plan. So whatever the event is, the general approach is the same. That way it's consistent and people are used to it and you don't have to reinvent the wheel on any new event. And then layered onto that are special precautions that you can you take in the event of a chemical or a biological or radiological, those types of things. Those are very rare, but there are special decontamination tents and things that we can set up in the event that something like that were to happen.
In addition to practicing different disaster scenarios, Harborview physicians and researchers are also constantly updating their approach to treating trauma. Lessons gleaned from far-off places like Afghanistan and Iraq.
Unfortunately, we learn something from every major conflict, and the most recent conflicts, of course, have had very challenging patterns of injury related to IEDs, and you might think, oh, well, we're never going to see that in the civilian community. What can we learn from that? But actually, we learned a tremendous amount. Obviously, you can see it. We saw that in Boston, and the lessons that were learned from management of those injuries were directly applicable to how people were treated in Boston. The use of tourniquets, for example, which in the past had been discouraged in the civilian community over the past several years because of the experience in Iraq, have been promoted. And so now all of the EMS units are carrying tourniquets, and they were widely used in the Boston event.
One current study that Dr. Bulger, Chief of Trauma at Harborview, is particularly intrigued by and involved with is the clinical trial to identify the precise combination of blood products to deliver to a rapidly bleeding patient.
What most people don't know is that when you donate blood, it's broken up into its components. So it's sort of taken apart. So you can give back patients either red cells, you can give them back what's called plasma, which has got all of the clotting proteins in it, or you can give them back platelets. And those things are all taken out of blood that you donate into separate packs. And what came out of some of the experience in the wars was that patients might do better with a different combination of those products than we have traditionally used in the past. And so we're currently studying that to answer that sort of fundamental question across the U.S. And we expect to have results from that study probably by January. And I think that'll has the potential to fundamentally change what our strategy is for initially giving blood products to these patients. So I'm very excited about that because it's a very important clinical question.
Thank you, Harborview's Dr. Bulger.
You're listening to the UW Medicine Pulse and a bit of history.
Prior to the 1970s, emergency departments were largely staffed by rotating residents or internists or even surgeons who were sort of taking their turn staffing the emergency department. They weren't necessarily a place where people wanted to work all the time, and there was no specialty training in emergency medicine. That has evolved over the past several decades. Now there's a specialty in which emergency medicine physicians, you train as a resident like you do any other specialty. And so the emergency department has evolved to offer acute care, we offer emergent care, we offer ambulatory care, and we essentially offer inpatient care as well.
That is Susan Stern, UW Medicine physician and division head of emergency medicine at UW Medicine. Up next, among the many historical milestones attributed to Harborview Medical Center is the creation of Medic One, one of the country's first emergency response programs.
Out here with the attack guys now, Captain. We have our kit with us. We're going to stay on scene.
Because, as we'll find out, sometimes the most important emergency treatment you receive is the care you get before you arrive at the emergency room.
Medic One was an experiment, and it was an experiment by the University of Washington in our community. If you went back a few decades ago and you had a cardiac arrest in Seattle, you would have died because the only system set up was an ambulance that would take you to the hospital with no care provided on scene.
We're here on the streets of Seattle asking passersby about their knowledge of CPR. Have you ever been trained in CPR?
Yes.
You have. So do you know the routine? If I were to fall right now, what would you do?
Well, you listen to make sure they're breathing, tell someone to call 911, and I don't remember the numbers, but I know how to do it.
If by chance I were to collapse right here, what would you do?
Not CPR. Isn't that only limited to drowning?
Oh, it could also be used in case of a heart attack.
Oh, that's good to know.
Probably just call 911 and let somebody else take care of it.
Have you ever been trained in CPR?
I took it before they did the American Heart Association did the new, because you don't do the breathing anymore, so I haven't been specifically trained on the new technique, but I do know that you don't breathe in, but the way you want to do it, the most effective is to get the blood circulating, so just the chest compressions.
If you had a cardiac arrest right now and you were not in a hospital, your chances of survival would be very small, and if no one in this room knew CPR, they'd be absolutely dismal.
Peter Kudenchek is a UW Medicine physician, professor of cardiology, and associate medical director for King County Emergency Services.
In Seattle, King County, we have a system that if you call 911, the operator, once identifying the fact that you are calling on behalf of someone who has a cardiac arrest, will not only summon providers to the scene, and they will get here within 4 minutes, they will instruct you to do CPR on the spot, on the telephone, to start that until the emergency medical service providers actually arrive. That has been instrumental in getting the public to do CPR in more than half of cases of cardiac arrest in our community that otherwise wouldn't have happened, and are a major contribution to what happens.
Recently, though, there have been reports that the approach to performing CPR has changed somewhat. What's the story behind that?
The traditional way CPR has been taught is you press on the chest and then you move to the mouth in order to breathe. A few years ago, we became concerned that the public in particular is not willing to do that. It's very complicated to shift from the chest to the mouth, and simply putting one's mouth on a stranger is a big issue. So the American Heart Association recommended that for lay people, not professionals, but lay persons who do CPR, press on the chest. Don't worry about breathing, because if help is on the way within the next few minutes, trained providers will come on scene and they will institute traditional CPR. But for the first few minutes, get on the chest, press hard, press fast, and you'll be doing a terrific service for that patient.
So does the research show that we're somehow compromising patient outcome by not including the breathing with CPR as we were once taught?
No, in fact, I think what we've gained is that because more people are willing to do CPR that way, and typically on the phone, you don't have to train someone it doesn't take very long to tell them how to do pressing on the chest, whereas if you try to train them to press on the chest and then breathe for the patient, it becomes very complicated. There were 2 trials that were done, both of them done here in Seattle, King County, that evaluated this method of doing CPR. And what we observed was that survival was as good or better if you did it this way with the lay public versus the traditional way. But the advantage of this way is more of the public are willing to do it. So in the end, you have a win from that standpoint.
Thanks to Medic One and the work being done by Dr. Kudenchek and his colleagues at UW Medicine, King County has some of the best survival rates for a heart attack in the country and around the world.
Our survival rates are more than double what survival is in the country. If you had a cardiac arrest due to a dangerous rhythm called ventricular fibrillation in Seattle, King County, your chances of surviving would be nearly 60%. And you compare that with what the average is across the country, it's incomparable. We have the best survival numbers.
Do you know the difference between care you'd get in an emergency room and in an urgent care facility?
I would really probably take a broken bone or something really traumatic to the emergency room, and I would say for urgent care it might be something less if you're not feeling well.
I'd go to the urgent care center. If I had a massive coronary, I'd go to the emergency room.
Emergency care is usually like sutures that are dangerous or surgery, broken limbs, things like that.
Urgent care versus emergency care. Which option to choose when? Here is Fred Rivara, UW Medicine physician and chief of pediatrics at Harborview Medical Center and Seattle Children's.
Let's take the emergency room care, emergency department care. It's really for the child that truly has an emergency, a child with a broken arm, a major laceration that is bleeding, somebody who is having trouble breathing, somebody who seems very ill. That's really going to the emergency room. For other kinds of things that you might normally go to your pediatrician's office for, your family medicine doctor's office for, when they're closed, that's probably more an urgent care kind of a problem. The child who has a high fever and an earache, the child who has bad coughing and just you can't wait until Monday when the office is opened up to see the physician.
So what does this mean for you? Well, most of us, unfortunately, at some point will require some emergent medical care. The need arises unexpectedly. It's often a tense or frightening time. And where you go to seek treatment is vitally important. There's urgent care for non-serious conditions outside of normal physician hours. Emergency rooms cover the more critical, time-sensitive, and potentially life-threatening conditions. And when it comes to serious trauma, you typically don't have a choice as to which trauma facility you get transported to, but it is reassuring that we have one of the top treatment facilities in the country at Harborview Medical Center. Harborview's Dr. Fred Rivara.
And we found out that for severely injured patients, you're 25% less likely to die if you come to a Harborview, a level 1 trauma center, than if you go to a community hospital.
Plus, the experience that doctors at Harborview get treating extreme cases of trauma translates to better patient care in general for less complex procedures.
You're watching the news at night or something like that, and you hear, oh yes, they were taken to Harborview, so what does that mean to me? I know what that patient's going to go through. You know, I know that they're actually going to get the best care.
Thanks to Ann Newcomb and the entire staff at the Harborview Emergency Department for allowing us to observe their operations. Thanks to all of our guests, Doctors Eileen Bulger, Peter Kudenchek, Susan Stern, and Fred Rivara. If you'd like to know more about this topic or future podcast topics, visit our online home at uwmedicine.org/pulse. We'd also love to hear from you, questions or comments. You can submit those on that site as well. If you'd like to receive every episode of the UW Medicine Pulse podcast as they are released, please subscribe to us via iTunes. The UW Medicine Pulse podcast is produced by Tina Knoll, engineered by Shelley Goncharowski. I'm Marty Reamer. Thanks for listening.